Good afternoon. My name is Deontay Marquis. Um, I am a master's educated nurse practitioner, family nurse practitioner, and today I will be presenting to you on behalf of my ALF Training, and we will be covering activities of daily living. Now, this is a three-part presentation, so this is part one of the three-part presentation, and I will be presenting to you all three parts. So let's begin. Okay. So first, of course, like I said, my name is Deontay Marquis, and this is ADL Part 1. So we're going to begin by reviewing our course objectives. So our course objectives for Part 1 of the ADL presentation is first, I want to make sure that you leave this presentation and you leave with the understanding and being able to identify readily the diseases that are most common to the patients that you'll be taking care of that will be demanding assistance with their ADLs. Um, Next, I want to make sure that you leave this presentation knowing how to correctly care for and assist those patients with bathing, as well as dressing and grooming. And lastly, you should be able to implement various approaches to specific situations with these patients that will help you help them successfully complete their ADLs, because not every situation, of course, as you already know in medicine, will be exact and will go according to plan. So we need to know different approaches to make sure that the outcome that is needed is one that we can attain. So, first, of course, some of you may already know, some of you may not. What is an ADL? I remember when I was in nursing school, I used to always get it confused and think that ADL stood for Assisted Daily Living, but that is not correct. ADL stands for Activities of Daily Living. Now, these activities are specifically tasks that we perform on a day-to-day basis that enable us to live successfully as independent human beings. So basically, they're more kind of a care, self-care activities such as bathing, eating, showering, cleaning up our home, paying our bills, exercising, things like that. So those are considered activities of daily living. Now, who needs your help with completing their ADLs? So in an assisted living facility or just throughout America, some of the most common diseases that render a patient unable to complete their ADLs independently, which as an end result leads to them uh, being in an assisted living facility or hospitalized or just some type of caring environment where they need assistance. Those three diseases, which you will most commonly see, are dementia, patients who have had a stroke and are just trying to live their life with the residuals of that stroke, and also Alzheimer's disease. So these are the most common diagnoses that you will likely be encountering in the patients that you care for who need your help to complete their ADLs. So first, we're going to talk a little bit more about dementia, because in my opinion, in order for us to successfully care for the patients that need assistance with the ADLs, we need to understand a little bit about the type of disease that they are not suffering with, but have or are working through. So what exactly is dementia? Dementia is a little bit confusing at first, but it's really just an overall term that is used to describe it's used kind of like an umbrella term to describe a group of symptoms, which include memory loss, language difficulty, trouble problem solving, and any type of activity that involves a certain amount of thinking. So dementia affects a person's ability to, I guess, if you will, think up to a certain normal level like you and I. It makes just overall their everyday activities that much more difficult. So, for instance, they'll have trouble with memory. They'll be extremely forgetful. They'll wake up from sleep in the morning and they'll forget where they are. They will forget what time it is. They'll forget what they wanted to do next. So they need someone to care for them and assist them because this trouble that they have with thinking affects every activity, as you can imagine, that they try and perform throughout the day. Let's see. So that's dementia. Let's talk about stroke. Stroke is another very common disease and is actually, I believe, the number one or number two leading cause of disability among Americans today and has been for several years. So chances are that you will be taking care of a patient that has had a stroke. And keep mindful that every stroke patient is very unique given that given that the stroke that they had leaves sometimes different varying symptoms from the stroke. So for instance, patient A may have had a stroke 10 years ago and you may not notice much disability caused from the stroke. They may have some trouble speaking, but overall they seem very normal. While patient B may have had a more severe stroke 10 years ago and they're having a lot more trouble with their ADLs. They're having trouble speaking. They're having trouble walking. Their left arm may be paralyzed. So you need to keep that in mind when you're taking care of a patient with a stroke, because each patient, of course, is very different from the next. So let's get into more a bit about what is a stroke. So a stroke occurs when blood supply to part of the brain is interrupted or reduced. Now, this can be due to the patient having a history of hypertension or atherosclerosis, which is just a buildup of plaque. So they've been living a very sedentary lifestyle. They may have been overweight. It may have been a combination of being overweight, drinking, lack of exercise, smoking. So all those things together, for whatever reason, this patient was unfortunate and they suffered a stroke because blood flow for however long was stopped. And so brain cells began to die, and this caused these symptoms you see on your right. And once a brain cell dies, that is permanent. So whatever brain cell controlled, so whichever body function that the brain cells which died controlled, that is permanent. These patients go through physical therapy to sometimes decrease the severity of muscle weakness or paralysis, but more than likely, they will never be how they were before they had the stroke. So, a stroke, this is definitely the type of patient you'll see and you want to pay close attention to when you're helping them perform their ADLs. Now, Alzheimer's disease. Alzheimer's disease is the most common cause of dementia in older adults. So, as we're living today in the year 2020, we're going to see more and more of an aging population, and dementia is something that's going to become more prevalent in today's society, and especially in the assisted living facilities and care facilities that you're working in. So you need to become familiar with this disease, familiar with these type of patients, the symptoms, and how to care for them. So, the most common cause of dementia in older adults is Alzheimer's disease, which is a progressive degenerative brain disorder. So, it's just kind of a natural degenerative brain disorder that a patient may have been predisposed to for whatever reason. And it has effects on their behavior, their social skills, their ability to think. And this can present in a myriad of ways. It can present as memory loss, it can present as confusion, mood swings, they can have episodes of agitation. So these are all that these are all symptoms that you want to make sure you look out for when caring for a patient that has Alzheimer's disease. And you also want to keep in mind that again, each patient is unique. Let's get this presentation up again. Okay, Alzheimer's. So moving right along, our first ADL is bathing. So bathing is one of the cornerstones of ADLs. It's something you need to get very familiar with, especially if you're dealing with elderly patients who sometimes do suffer from incontinence, or patients with dementia and stroke, like we talked about. They are forgetful, so you will be cleaning these patients up, assisting them with bathing and caring for them. So bathing is an essential everyday activity that many patients need assistance with. Knowing how to properly bathe a patient to ensure their safety and uphold their dignity, that's very important amongst the elderly, is because we want to make sure at all times we uphold their dignity, is a vital skill. So first, for bathing, I'm going to show you a video of how to not properly bathe a patient. Here we are. Let's take a look. So notice we're turning on the water. She already got the
Mom, it's
water
8
ready.
a.m. Time for your shower.
She has a towel.
I don't want one. Mom, come on, please. We've gone over this over and over.
No, leave me
It's been
alone.
a
Don't
week.
touch.
Come on. It's been a week since your last one. You need one. Please get undressed.
She's a little pushy there. She demonstrated to her that she's very upset. She demonstrated that she was upset in her body language. And you can see how it also impacted the patient, who gave her like a look of confusion and kind of reacted to her reaction of frustration. So, bathing. That is how not to properly bathe a patient. So, bathing. First, preparation. So you want to make sure that when you're preparing to assist a patient with bathing and completing this ADL, that you first start off with preparation. So items, you want to make sure that you have soap, you have a washcloth, you have a towel. If you plan on washing their hair, you have shampoo, you have conditioner. If you plan on doing some care afterwards, you have the ointment ready, or any lotions or perfume or anything that you may need. You want to make sure that you've gone through their belongings with them, you've gathered the supplies, and you've laid them out on the bed or in the bathroom, on the sink. You want to make sure you have everything ready, because like we talked about, a patient with a stroke sometimes may have muscle paralysis. So this is the type of patient that you do not want to leave alone. Or even your patients that have dementia, you want to refrain from leaving these patients alone, especially while performing bathing ADL, because it's wet. They're more prone to falling because the bathroom is likely tiled, so it's more slippery. So be prepared. Next, make sure the bathroom is warm and well lit. Yes, so we want to make sure that the lights are on, all the lights are working. We want to make sure that if the air condition was on, you've turned it off. We want to make sure that the fan is off and that there's no extra fans blowing, that the patient feels comfortable in the environment. Um, and because if they feel cool while before they've taken a bath, then it's more than certain that they'll feel cool after they've taken a bath and they're wet. So we want to make sure that the bathroom is warm. And that's something in the video we saw that was not done. Be matter of fact about bathing. So you want to be very matter of fact. You want to be very direct, firm, but not confrontational. You don't want to engage in an argument. You don't want to engage in a back and forth with the patient. You want to say, it's time for a bath. Let's go. You don't want to go back and forth. This is why, that's why you haven't bathed in a week. You don't want to do those things because the patient may not be able to articulate exactly why they don't want to take a bath, and you going back and forth with them may just make them more frustrated and less likely to want to allow you to help them take a bath. Make sure the water temperature is comfortable. How would you do this with the patient? You use a handheld. That's why it's very important to use a handheld. If the patient isn't able to stand for very long, which elderly patients, I would be um, a little distrustful of an elderly patient standing for an entire bath. Preferably, I'd have my patient sitting in a shower chair, or we do a sponge bath at the bedside. So you want to take the handheld and you want to get the water to a temperature you think they would like. Let them feel the temperature on their feet, on their hands, make sure it's okay, and then proceed with the bath. Don't use bath oil, just a tip. It can make the tub slippery, and it also can cause urinary tract infections in women. So you want to make sure that when you're choosing, or even when family brings over certain products for the patient, you want to make sure that it is a product that is safe for the patient to use, and it's not an oil-based product, and it's not something that could possibly cause a urinary tract infection for the patient. So bathing, preparation, we talked about supplies. We talked about water temperature. Now we're going to talk a bit about privacy. How do you maintain patient's privacy during bathing, which is such a revealing, if you will, process or activity? Well, you want to make sure you have extra towels. These towels can be dry, or you can even wet the towels with warm water before the patient gets in the bath, or while they're sitting in the chair, and drape the towel around them. Make sure that any area that's not being washed is covered. This will make the patient feel more comfortable. It'll keep them warmer. They're less likely to report feeling cool. And this will maintain their privacy and dignity and make them feel comfortable, and they'll enjoy taking a bath more. And environment comfortability, we talked about the temperature in the room. We talked about the water temperature. Make sure the door is closed so no one can come in, or if you can't leave the door closed at your facility for whatever reason, make sure you put a sign that lets your coworkers know, hey, I'm bathing this patient. Don't come in, because I want to make sure that this patient's privacy is maintained. I don't want them to be startled while we're in this tub, because I don't want them to jump up, refuse the bath in the future, or slip in the tub because you came in to look for me or to share something with us, and it startled them and they fell. So that's very important. Supplies, water temperature, privacy, and environment comfortability. All right. Now, how should our behavior be during bath time? We want to make sure that we encourage patient participation. How can we get a patient to participate? Well, if the patient is able to or willing, then we encourage them to participate. I'm going to wash your feet. Would you mind washing your chest? Would you mind washing your hands? Would you mind washing under your arms? Would you mind combing your hair? I'm going to wet your hair and put shampoo. Would you mind combing the shampoo through your hair? Very simple. Make it seem like it's a teamwork. Make them feel like you need their help to complete this task. Make sure that they know that you're there to help them. These elderly patients, they've already lost so much of the independence that they had by coming into an assisted living facility. We want to restore that independence every chance we get. This bathing is a huge way to boost their confidence, to increase patient participation, and to make this activity more enjoyable for them and for you. Covering the body. We talked about this. This is very important. You want to make sure that they're covered while they're bathing, and you want to make sure that they're covered when they come out. And you're putting lotion or any cream. You want to make sure that their body parts are covered. And if it's a body part um, that they don't mind being covered, you still ask, would you like me to cover your arms? So what I mean to say is if it's not a private area, if it's just their leg or their feet, would you like me to cover your feet? Would you like me to cover your legs? Because you don't know. It may be an area that they're embarrassed about. They may be cold. So we always want to offer covering of the body. Also, talking the patient through the process. This is very important and has a huge impact on the patient and how this activity goes. We want to talk the patient through the process. Before you bathe their legs, you want to say, okay, I am getting some more soap, and next I'm going to wash your legs. And you wash their legs. Oh, I'm scrubbing your legs. I'm almost done. I'm going to go to the next leg. Okay, I'm going to the next leg over here. I'm almost done. How are you doing washing your hair? You're doing great. Okay, I'm done. And then I'm going to rinse your leg. Here's the water. The water is a little warm. The water is a little cold. You want to give them a heads up about what's going on. Just to make them feel more comfortable. And also because these patients, like we talked about, are likely to have dementia or to likely have some trouble thinking and understanding what's going on. So by you constantly reminding them, it decreases the chances that they'll become agitated or confused and stand up and want to leave or suddenly have a mood swing about what's going on. Very important. Patient perceived control, adapting the process. What does this mean? How do we adapt the process for a patient taking a bath? Well, I'm glad you asked. So we can adapt the process by having some type of flexibility in the time. If you go to your patient in the morning to offer a bath, and they don't want a bath, you say, okay, well, what about this afternoon? Or what about tonight? Know that as healthcare workers, we have a schedule, we have a lot of things to do, but we have to remember that sometimes when we want things done, it's not the best time for the patient. Um, so if the patient wants to be bathed at night, and it just so happens that this is the time at night is when you usually give medications or walk the patients and do something else. And this is a little bit, it throws your schedule off a little bit. We have to be more flexible with these patients and understand that, like I said, this is the last bit of independence. They've given up so much already. Let's restore that independence to them, allow them to be involved in the process and be flexible to their wishes. Also, some patients just don't like baths. Maybe they fell in the bathtub before. Maybe they had a bad experience with the bath. For whatever reason, let's say the word bath or shower may be a trigger word for them. And anytime they hear it, they just say no. So we think of some other words. We can say water time or cleanup time, things like this, or spa time, things like those words. Just something other than bath or shower. Make bathing time inviting. If you have candles at the facility that don't use a flame or some kind of fragrance or aroma that the patient likes, we can put those in the bath area, or we can turn those flameless candles on during bathing time, or we can turn on music. Things like this do make a difference for the patient, and they will make uh, bathing the patient an easier activity for you to assist them with. Now, aftercare. These are just some tips I'm going to share with you for after bath care that I want you to be mindful of when caring for the patient after giving them a bath. So, to prevent rashes or infections, you want to make sure you pat the patient dry. Remember, these patients are elderly. Some of them may not be well nutritioned. All of this affects their skin integrity. So we want to make sure that we're not wiping the patient dry too rough We want to make sure we're patting them dry with the towel, because we don't want to exacerbate any prior skin conditions they may have. And always be sure to dry in between any folds they may have in their skin. Also, if the patient is incontinent at times, you want to use a protective ointment. This can be a jelly or any type of petroleum-based cream. Um, and you want to place it around the hot spots, such as the rectum, the vagina, or the penis. Any area that is directly in contact with urine or feces that is more predisposed to breakdown because of irritation due to incontinence. If the person has trouble getting in and out of the bathtub, do a sponge bath instead. Don't force them to get into the bath because it's easier for us. We want to do what's safest for them at all times. So doing a sponge bath. And even sometimes, I know in my practice, sometimes the patients request to take a bath, like they request to take a normal bath, but it isn't the safest thing for them. And it's very unfortunate, but you have to let them know this isn't the safest thing for you right now. You're not as strong on your feet as you may think, or remind them you've had a stroke and your right side is paralyzed. So helping you to the bath to take a bath right now isn't the safest thing. We're going to stay on the bed. I'm going to give you a sponge bath. A sponge bath is going to be just like the real thing. We're going to get you just as clean. Don't worry. So before we move on to dressing and grooming, which is our next activity of daily living, we're going to revisit the first video we saw, and we are going to look at how to properly bathe the patient. So here we are.
Hey Mom, it's noon. It's time for your spa treatment.
Oh, I don't really want to go.
But you love the spa. Makes you feel like a queen. Yeah, and after that, we'll go to your favorite restaurant for lunch.
Well, okay, I guess.
All
All
right.
right, good. Let's go. So first, let's start by unbuttoning your shirt. I'm going to do the top button, and then can you help?
I'll pause it here. So just notice how she's getting the patient involved, and she said, "Can you help?" So she's getting the patient. That's patient participation. We talked about that, and if you remember, she approached her on the sofa a lot differently than in the first video. She used the word spa. She said, "I'm going to take you, I believe, to your favorite restaurant to eat afterwards." Just making this a more exciting activity for the patient. But if you see in her face, she still has a little bit of worry about it. But you can see just the tone of her demeanor and her face. It's a lot more inviting than in the first video. So let's continue.
Okay.
Okay.
Okay, she's participating.
Good job, Mom. Okay, Mom, I'm going to put a little water on your toes. Oh, test it. See if it's okay.
She's letting her mom test the water. She had candles lit.
It's
She's got
warm.
covered,
Good.
even though it's just them in the bathroom.
Now let's wash down there. Can you do that by yourself?
Yes.
Great. Okay, we're almost finished. I'm going to turn the water pressure on low.
She's talking her through
And fill
everything
up this
she's
cup.
doing.
Some water. I'm going to stand up. You just sit right here. Okay? Just lean your head back and pour a little bit of water on you. We're going to gently massage your hair with your favorite gardenia
She's talking her
scented
through
shampoo.
everything. She's got her favorite shampoo. She reminded her, "I have your favorite shampoo here." So this is great. That's a lot different than the first video we watched. And she's doing everything that we talked about. So I hope you guys were able to see the difference there on how to properly get a patient more excited, more involved, and an overall improved experience in bathing for the patient. So moving right along, we're going to go to our next ADL. So we've already bathed our patient. Now we're going to get into dressing and grooming. Okay. Now grooming. Grooming, personal hygiene in particular. We're going to talk about oral care, instructing the patient through the grooming process, and then how to properly brush their teeth, um, and washing the hair of the patient. So I do have a video for us to follow along here as well. Okay, and here we are, this gentleman, this young lady here.
Avoid being bitten. Fingers should be placed only inside lips or cheeks.
So she's using this toothbrush here to avoid getting bit. You should never put your fingers inside of a patient's mouth. So she has one toothbrush gently placed in between the patient's teeth so they can't bite down, and she used another toothbrush to actually brush the patient's teeth. You see the patient here fought her a little bit. This patient does have dementia, so he may be confused about what's going on or becoming agitated for an unknown reason. And look how she's gently grabbing him there. He has a hold of her, but he looks confused. He doesn't look violent. He's saying, no, no. So she's holding on to his hand there. And what she does, it looks like he just wants to hold something. So she grabbed a towel and put that in his hand. So now he can squeeze that. It looks like that didn't work. So she enlisted the help of another employee to help her. This employee is gently holding the patient's hands, rubbing him, likely telling him calming words, talking to him calmly. And here she is again trying to use the toothbrush, the two toothbrush method. Look, she's talking to the gentleman, trying to keep him calm. He's not fighting, but she's definitely holding on to his hands. So she was definitely holding on to his hands as she her coworker brushed the patient's teeth. This is a great way to help get through this process, which is a little bit more invasive, if you will, than bathing, because we're actually going inside the patient's oral cavity and brushing. And this may be uncomfortable for the patient because for a number of reasons. One to consider is they may have sore teeth. It may hurt. They may have sore gums, but likely because they're just confused about everything that's going on. Now, if the patient doesn't have teeth and the patient has dentures, either partial or full, you want to make sure that you use, you want to make sure that you take the patient's dentures out. Just like this lady here. So you put one finger in, you slide it at the top of along the side and up to the top of the gum. You remove the dentures, and then you still use a toothbrush to gently massage the gums. That's what she's doing there. You want to make sure you gently massage the patient's gums. You put the dentures inside of the proper case. You get a towel to line the bottom of the sink with. Run some warm water on top of the towel. Then you put the dentures on top of the towel. And see, she has a different type of toothbrush there, specifically denture brush. Wash that brush off, wash the dentures off, and then we're going to clean the dentures. This should be done twice a day. In the morning, of course, and at night. You should be taking the patient's dentures out at night to clean them, making sure they stay clean, and brushing their gums as well. Yep. So back to our presentation. So there we saw oral care. So I just want to add on to that what we saw, instructing the patient. Now, let's say that your patient that you're caring for doesn't have severe dementia and still understands what's going on, or perhaps has had a stroke and just has a little bit of a delay in their critical thinking ability and needs some instruction sometimes. So if that patient is able to stand, then you stand next to them, shoulder to shoulder, and you demonstrate how you want them to brush, how to properly brush. You talk them through it. Okay, I'm going to count to 10, and I want you to brush the left top side of your mouth. Then I want you to move to the bottom. Then I want you to move to the front. and then the right, and so on. You want to make sure you're also demonstrating so that if they forget or become confused or worried or what have you, they look up, they're looking in the mirror, you're right next to them, you're talking them through the process. And that is perfect. That's how you do it. You make sure that you're there to reassure them, to instruct them, and as an example for them to mirror. So they have to do no thinking, they just watch. Um, we talked about properly brushing the teeth 2 times, once in the morning, once at night, washing the patient's hair. Now, every facility doesn't have the shower washing caps. If you do have the shower washing caps, that's great. This is something that washing the hair is something that doesn't need to be done every night. But when you do wash the patient's hair, you want to make sure that you have a tear-free soap, shampoo preferably, that they lean their head back, that we put a towel over their shoulders. If the patient is unable to stand and you're doing a sponge bath, and you want to make sure that you massage it gently into their scalp, wash the hair, and then as we saw on the previous video for bathing, the young lady used a cup full of warm water to then rinse the soap out of the patient's hair. So we talked about oral care, instructing the patient how to properly brush, washing their hair. That's a lot about personal hygiene. You want to establish a routine with the patient. So you want to make sure that bathing, we can be a little bit flexible, but the grooming and personal hygiene, we want to establish a routine. We want them to wake up and we want to have the toothbrush, the toothpaste, the deodorant. If it's a woman and she likes to wear makeup, we want to make sure we have the makeup, everything ready for the patient, establish a routine. First we wash our face, then we brush, then we apply deodorant or we apply makeup, and then we proceed with the day, or we walk around outside, or you give them their morning coffee. Establish the routine so they know what to expect. We follow the routine so there's no surprises, and it's something that they become accustomed to, and try and make it fun. Try and make it something that they look forward to. Maybe play some music while they do this, or play their favorite song at the start of this personal hygiene grooming routine. And what grooming tools do I use? Now, this is something that you want to discuss with the family, and you want to assess the patient first, because not every patient is going to be the same. Some patients may perceive certain grooming tools as scary. If the family bought them a battery operated automatic toothbrush, this may be a tool that is a little bit scary for them, or they may not like it. We want to try different tools and different grooming tools to see which one they're most comfortable with. And then after we see which one they're most comfortable with, we want to then proceed with that one, of course. Men with shaving, they may not like an electric razor, but shaving with an actual razor blade may not be the best idea for them because they may be on a blood thinner. So we need to talk with the family or the facility to see what tool would be best for this patient. Maybe we need to let the family know, hey, this automatic electric blade that you have is a little loud. The patient seems to be a little scared and apprehensive to help me use it with them. Can I suggest this? Or is there any other shave razor that you see and you can bring it in and we'll use it with them? So keep that in mind, that it may not be the activity, it may be the tool that you're using to complete the activity with. Next up, dressing. So we've gotten through most of the morning already. We've bathed the patient, we've performed grooming, and now it's time to get them dressed. So clothing selection. This is very important, and a lot of little nuances that even I didn't really become aware of until I got into formal education and my master's education, that I learned about these little things that play a big role in helping the whole picture come together. So patients with dementia, when caring for them, we want to lay out the clothes in the order the person will put them on. So this is a patient who doesn't need too much help actually putting the clothes on, or they might, but either way, whoops. Either way, we want to make sure that we lay the clothes out in the order the person to put them on. So what does this mean? That means first, on top of everything, we have their underwear and their socks. And then we have their undershirt. And then we have their actual shirt and pants, and shoes are last. If the person is able to dress themselves, you want to make sure you're handing them one item at a time, preferably keeping the other clothing items out of sight. Because while you're handing them that one item, they're looking to see what you have next. They're getting a little confused. They're getting a little anxious about it. They may say, oh, I don't want to wear that today, before they've even put it on. And it makes the process of them choosing what they want all the more difficult. So we want to use a step-by-step, one item at a time approach. Possibly, if you can, you want to put away a lot of their clothes. If they have a lot of clothes, you want to put those clothes away, and only exchange them every week. You only want to have 3 outfits or 5 outfits for the week at the time. You don't want their whole clothing selection to be visible every time you go into the closet or they go into the closet to get some more clothes. You don't want them to have a lot of choices, because they'll get confused, they will get overwhelmed, and this will make the process more difficult for them, and this will make them a little more frustrated. So by keeping only 1 or 2 or 3 outfits in the closet or the dresser, this can make clothing selection a lot easier for the patient. Also, you and I have a favorite outfit. I'm sure the patient has a favorite outfit. So we want to identify the favorite outfit, the favorite color, the favorite pants. Are they sweatpants? Do they have an elastic band? Do they have a belt? Do they have suspenders? If it's a woman, is it a sports bra? Is it a dress, a loose fitting shirt? What is it that they tend to enjoy wearing the most and say that they feel the most comfortable in? We want to make sure that we have several sets of those items, because sometimes the patient wants to wear the same thing every day. But of course, we can't do that because the item has to be washed and such. So we want to offer them the option that they want as often as we can. And we can do this by having several sets of these clothes for them to choose from. Again, we're going to continue with clothing selection. The clothes should be something that they feel comfortable in. It should be loose fitting, sweatpants or shorts with elastic waistbands. All tend to be a very common, popular choice of a comfortable type of clothing. Shoes. We talked about shoes should be the last thing that are given to the patient to put on, obviously. Velcro tape or zippers are primary choices over shoelaces or buttons or buckles, things that are more difficult for them to take off, and they will more likely need help with. We want to make sure that these patients retain as much independence as they can, because we want them to participate. We want them to feel as though we're there to help them, not that they're relying on us to help them, because that is when the frustration and the agitation that they can no longer do these things for themselves seems to set in. Slip-on shoes that won't slide off is also another great option for patients. So these are some things to keep in mind when we are dressing the patient. The clothing selection, very important. Closet organization. My mother always told me to keep my closet organized, and we should tell our patients, and we should do the same thing for them. The closet should always be neat and organized and free from clutter. This patient may have been a complete neat freak before they moved into the assisted living facility, or before they were unable to keep their independence and unable to keep their closet as clean and neat as they like. So we want to make sure we do that for them. How can we do that? By limiting the amount of clothes that they have that are visible. We want to tuck as much of the clothing as we can away into drawers. We want to keep their favorite options out, and we want to have several options available of that. Keep it free from clutter so that we're never searching for a specific item. We always see it there in front of us. A minimal amount of clothes makes the maximum amount of choices. That's what we want to remember. So next, we are going to talk about taking medications. This will be the last portion of part 1 of our ADL presentation, taking medications. So first, again, we're going to revisit a video. We're going to start off this lesson with a video that explains to you, or demonstrates, I should say, how not to administer medications.
Time to take your medicine, Grandma.
I don't need to take medicine. Who said I have to take that medicine? For what?
What are you talking about, Grandma? You have high blood pressure and diabetes.
Okay, she's explaining to the patient why she's taking the medications. This, we would normally think, would be the right thing to do. It would work. The patient would say, oh yeah, I do have high blood pressure. I was prescribed that medication. Let's see.
Dr. Brown said, if you don't take your medicine, you're going to get sick.
I don't need pills.
Why do we have to do this every day? Just take your pills. I give up.
Well, we can see that that was not the best way to handle this situation, and we will have to see how to properly handle that type of situation, which is the most common problem that we face with patients in the hospital, and that's whether they are they have some type of dementia or Alzheimer's disease, or they've had a stroke, or they're perfectly healthy and just came in for broken leg. They don't want to take certain medications, and they have every right not to. But we need to make sure that our elderly patients take their medications because they are not making the best decisions with a sound mind as they once were, because of the diseases that they have, because of the dementia, because of the Alzheimer's disease. They're not remembering why. That just yesterday they were happy to take this medication, and this morning they're knocking the cup out of our hand and they're telling us to get out because they don't want to take the medication. So how can we do this? We need to work as a team. We need to work with the doctors. We need to work with the our other employees to make sure that we have our medication ready. We understand why the patient's taking it, and we're all on the same team when we go in to talk to a patient. And make sure, if you're going into a room to talk to a patient, that you and your coworker or doctor or manager or whomever are not talking to the patient at the same time, because this will the patient will automatically feel as though they're being ganged up on, or they're being singled out and fussed at, even though that won't be the case at all. So make sure we're working as a team. And then what do we do? You're probably asking me, well, Deontay, this happened to me before several times. What do I do if the patient refuses? First thing you do is you want to stay calm, and you want to try and think about why the patient might be refusing this medication or resisting to take it. And it's been a theme throughout this entire presentation, is the patient feels like they're losing their independence. They don't want to take a medication, but they have to, and they certainly don't want to wait for you to bring it to them. So remember that resisting medication is just a response to feeling rushed, or maybe they're afraid about taking it, or maybe they're confused about what they're supposed to do. Maybe they don't like taking pills. It's a bunch of there's a bunch of reasons why. But number one, we should ask ourselves, are they feeling a loss of control that could be causing this response of resistance and anger? Yes, they totally are feeling a loss of control of the situation. So we want to give them time. We want to give them time to process what's going on. We want to give them the time to talk to them, to understand what's going on. We're taking this medication because your blood pressure. Remember yesterday your blood pressure was high? Remember you had a headache? This medication is going to make sure that that doesn't happen. This medication is going to keep you healthy so we can go on long walks. Do you have any questions about this medication? Do you remember the last time you took this medication? You didn't have any side effects. You didn't feel nauseous. There's nothing to be worried about. Excuse me. So this is the type of tone, the statements we should be making to the patient. As far as our action goes on how to deal with a patient who's resisting the medications, we want to pour the water, but we want to allow them to pick up the medication. We want to always try and get the patient involved in an ADL or in whatever activity we are performing with them. So pouring the water, but allowing them to pick the pill up from the table. Also, you want to try and avoid, if your patient is taking a large amount of medications, don't put them all in one cup. I know it can take a long time, it can be very cumbersome, but it will ensure that if you're taking care of that patient on a day-to-day basis, when you come back, it'll build that trust with the patient so that a week from the first time you gave the patient those 20 medications one by one and talk them through it, you won't have to do that every time. You'll build that trust with the patient. And it'll also make them feel more comfortable, which is the most important thing here. Also, you want to avoid putting the pill bottles in plain sight for them. Some of them may not like the sight of pill bottles. A lot of people who are healthy don't like having to take medication. But just imagine how this patient may be feeling and make sure you give them time and work with them to change that feeling to a positive. Okay, that's how we work through resisting medications. Let's watch this last part of that video to see how we can properly handle that situation.
Time to take your medicine, Grandma.
I don't need to take medicine. Who said I have to take medicine?
She's sitting down next to her. She's listening to her, and you can see her face is just demonstrating a little bit of empathy. Like, yes, I do know you have to take this medication. Let's see how she responds to Grandma's question.
Remember, Dr. Brown said you have to take medicine for your blood pressure and your diabetes. He even wrote a note. My patient, Aura Jackson.
So you can show the patient the actual prescription. Say, hey, look, here's a prescription. Your favorite doctor, he really felt like you should take this medication. And look, your name's on it. There's nothing to be worried about. We're not making a mistake. This is for you, and it's not going to hurt you. It's going to help you.
To you. Needs to take her blood pressure and diabetes medicine every day. So let's take your medicine for Dr. Brown.
Okay, I'll take it today, but maybe not tomorrow, only because Dr. Brown said it's a good idea.
Okay. I have an idea. Let's take the dogs outside for a walk. It's a beautiful day.
All right. So notice how at the end, she actually let the patient hold the cup. The water was already pre-poured. She gave the patient the pills. They weren't in the pill bottle. They were in the pill box, which is a little bit less threatening, I would say, than a bunch of pill bottles. So try and make sure you have all the pills ready before you go into the patient's room. That seems to be a little bit less threatening to me. And then even after she gave the medication, she tried to turn the overall situation of taking medications into a positive by saying, hey, let's take the dog for a walk. So now when she comes back tomorrow, she can use that and say, hey, remember yesterday after our medications, we took the dog for a walk? Let's do that again today. So that would hopefully make the patient more likely to take the medications without as much resistance as we saw in the first video. So that concludes our last part of our part 1 of the 3 ADL presentation. But before you go, we're going to do 2 review questions just to test your knowledge and see how you fare in the knowledge we just gave. So this first question here says, a patient is refusing a bath for the 3rd day in a row. What is the best course of action to change their mind? Should we A, use gentle force to coerce them? B, allow them to refuse only if they agree to a bath tomorrow? C, persuade them by offering their favorite snack afterwards? Or D, call their family to speak with them about it? So I'll give you a minute. You think which answer is the best, and we'll talk about it in just a minute. Okay, so by now you should have selected an answer choice. Let's see what the correct answer is. C. The correct answer is C. If your patient is refusing to take a bath for the 3rd day in a row, the best course of action is to try and persuade them by offering their favorite snack afterwards, for example, offering to take them for a walk, for example, persuade them with using their favorite scented candle. Um, we shouldn't be coercing a patient to do anything, even if it's gentle force. Remember in the video we showed with the gentleman and we were doing oral care, we weren't coercing him, we were restraining him and calming him with a second coworker holding his hands. We shouldn't be allowing them to refuse again for a 3rd day. 3 days is too long to have a patient going without a bath. I would say 2 days is too long. And this type of situation that's described in the question doesn't indicate to me that we need to call their family to speak with them about it. This isn't something that we can handle as caregivers, and it's our responsibility. So we don't need to call and speak with the family. This is something we should use our communication techniques. We should be persuading them, offering things that they're interested in, trying to make the bathing environment as inviting as we can with candles or aromas or what have you, or music, to get through this situation and get the patient to take a bath. Question 2, which patient will most likely require a 2-person assist when standing? Is it patient A, the patient with a history of dementia who is sometimes agitated? Or B, the patient with a history of stroke and muscle weakness? Or C, the patient with a history of Alzheimer's disease who wanders off when left unattended? Or D, the patient with diabetes who just woke from a nap? So which patient is most likely to require a 2-person assist when standing? So we're getting this patient ready to walk to the bathroom or to take them for a walk. Which patient is most likely to require a 2-person assist? I'll give you a minute and we'll come back and we'll talk about the answer. Okay, so the correct answer to this question is B. the patient with a history of stroke and muscle weakness, this patient is most likely to require two-person assist when standing. It isn't A, the patient who has dementia and is sometimes agitated. This to me doesn't say that the patient will definitely need a two-person assist, because even though the patient gets agitated, that doesn't mean we need a two-person assist. We're trained to deal with agitation. Remember, we talked about using our calming voice, using physical touch, as we saw in the video. This person doesn't necessarily need a two-person assist when standing, because a patient can be agitated, but still able to stand without any problems. C isn't the right answer, because a patient with a history of Alzheimer's disease who wanders off when left attended, they physically can stand and they can wander off. So there's no problem with them walking. The problem is when they're unattended, they wander off. We shouldn't be leaving any patient with Alzheimer's disease, or any patient for that matter, completely unattended so that they wander off. We want to make sure we know where our patient is. And D, patient with diabetes who just woke up from a nap, there's no reason this patient can't stand. They may be a little sleepy. We wake them up, they should be fine. The best answer for this question is B. A patient who has a history of stroke and muscle weakness definitely needs a two-person assist. So, a quick review, lesson summary. At the end of this presentation, you guys should now be able to understand and identify underlying diseases that demand assistance with ADLs. The most common are stroke, dementia, Alzheimer's disease, which we've talked about thoroughly, and you guys should understand the symptoms associated with each disease and how each patient's needs to complete ADLs differs and how to care for them. Next, you should be able to identify how to correctly assist patients with bathing. We talked about safety measures. We talked about being prepared. We talked about patient participation and how to maintain their privacy and uphold their dignity. Third objective was how to identify how to correctly assist patients with dressing and grooming. We talked about limiting the choices that they have by keeping a lot of their clothes hidden inside the closet, tucked away, always choosing comfortable or loose fit clothing, and how to lay out their clothes and use a one-by-one, piece-by-piece, step-by-step approach to assisting them to get dressed. And our last objective, which we've completed, identify and implement various approaches to assist patients with taking their prescribed medications. As you saw in the video, we want to encourage participation in any way that we can. We want to remind them why they're taking it, assure them that it's safe to take it, just basically easing their worries, giving them time to understand that we're there to help them, this medication is good for them, and that they should take it, and remaining calm while we give them this time to make these decisions, to participate and take the medication by speaking softly. And those were our objectives for this lesson, and we can check them off. This concludes the end of our Part 1 ADL presentation. I will be returning to you again for ADL Part 2 and 3. Again, my name is Deontay Marquis, and I am presenting this presentation to you on behalf of my ALF Training. Thank you, and I hope you have a good day.